I'd like to thank the organisers for giving me this talk. The title is not mine. Have we reached the end? I think that's quite provocative and interesting, and I've tried to answer this the best I can. And the reason it's a good question is because the rate of change with treatment for hemoglobin disorders has really accelerated in the last 3 or 4 years. The number of new drug products which are coming through for thalassemia and sickle cell disease is almost bewildering. So I'm not going to try and cover those. A lot of those in any detail. A lot of these are going to be covered in the meeting. We're going to go through a lot of the new scientific trials later in the meeting. So what I'm going to do is just give an overview of where we are and where we're getting to. I think that a lot of the advances that have happened have been built on basic scientific understanding of the hemoglobin disorders, and for many years that was not translated, and it's only now that that has been translated. So I think I'm just going to pinpoint some of the key changes that have occurred over the years. I'm going to talk particularly about the chronology of thalassemia treatments, both curative and non-curative. And because the title says hemoglobin disorders, and because when I asked, do you want me to cover sickle, they said yes, I'm giving 2 slides only on the whole of sickle cell disease, which is a challenge. But the most important slide is at the end, or 2 slides, is are we there yet? Are we at the end? So if we think about the evolution of understanding of thalassemia disorders, this goes right back to 1925, the first description by Cooley, but a lot of other descriptions in the Mediterranean by Solastrone, Bianco, and so on, where the mechanisms of the hereditary basis of thalassemia was described. The structure of hemoglobin was described by Pauling in 1949 and then further work up until 1960. The importance of globin chain imbalance to ineffective erythropoiesis and the pathophysiology of thalassemia disorders was highlighted by the work of Weatherall and Clegg, but has been carried through by many investigators. And because I'm not going to mention this later, the advances in genetic mutations and its impact on prenatal diagnosis has been really important from around 1980 all the way through to the present time. When it comes to the management of thalassemia disorders, I think our experience in the UK shines a light on that evolution. If you go back to 1960, there was just transfusion and people were dying very young from iron overload. Intramuscular Desflower was first introduced by a nice study from the Royal Free with Bernadette Medell and others. And then subcutaneous treatment came in 1980, both in the United States, in Boston, and in London. In this chronology, bone marrow transplantation was introduced by Lucarelli, and the basis for defining different categories of risk were determined. Deferapone came in London around 1987, or possibly a little earlier. Very importantly, cardiac magnetic resonance imaging, or T2-STAR, was introduced around 1999 in London. This had a major impact on how we manage patients and has allowed the stratification of risk and intervention with our patients. And then finally, in this chronology, Defer-Sowitz came in around 2007, and it's had a big impact on the options available with respect to treating our patients. Now, before this evolution, cardiac death was the major problem, cardiomyopathy or arrhythmias. But since this time, the survival has gradually improved throughout the world. So here are some survival figures from the UK, showing the overall survival in the UK in the top left. In the top right, the overall survival in our patients at UCLH, where we introduced intravenous Desferal through Portacast very early. We were able to rescue a lot of patients, even though they were already in heart failure. And you can see the Italian data is very similar, a very strict cohort effect. That is to say, the earlier you were born, the less likely you were to survive to the age of 20 or 30. And that has a lot to do with the age of introduction of chelation therapy. So if you see this scheme that was put together by Bernadette Modell, you can see in the 50s to early 60, patients were dying of anemia. They weren't getting enough blood. Then blood, that's the pink. Then blood began to be introduced, and people started to die from the effects of iron overload. And this persisted right the way through until about 2000, 2003. And then we had, by this time, we had at least 2 chelators, and we also had the CMR, which I mentioned, the way of measuring iron both in the liver and the heart. And you can see that in the cohort of our patients who have been followed since around 1999, that the cause of death has changed very significantly. So now patients, the death rate's gone down very substantially, that's the important thing, and people are tending to die from liver complications, hepatitis C, malignancy, or infection. We must remember that throughout all this time, infection has been the second commonest cause of death, and we need to do more to tackle the high risk of infection in these patients. So if you look at the mortality rates in our centre, it's very substantially less than the historical mortality rate. So that's a success. Are we there yet? Cardiac iron overload has gone down, so if you take mild cardiac iron overload, a T2 star between 10 and 20 milliseconds, that has dropped very substantially. And the severe cardiac iron overload, which means that you've got a very high risk of going into heart failure in the next year, has fallen from about 25% to 7%. So a very substantial reduction in heart iron and in mortality over this period of time. This is the age distribution in London at the UCLH and the Whittington hospitals, and it shows two things. There's a peak. The most common age group now is around 30 to 35. There's a big fall-off under the age of 30. Why is that? Well, that is not because the younger patients are dying, because they're not being born. So we have antenatal screening, we have prenatal screening, antenatal advice, and the birth rate with Thalassaemia Major in southern England particularly has dropped substantially. We have hardly any births now. This is in contrast to some parts of the world. Secondly, you can see when patients were born. So here we have patients born in 1985 or in 1975. So if you were born in 1975, the chances are you may have received chelation therapy in the first 2 years of life. But if you were born before that time, then you didn't get your first chelation until you were 10 years, 15 years of age or so. Many patients died. Or those who didn't die have got a lot of comorbidities from the effects of iron overload. So this is why the age of exposure to chelation therapy is so important. So that's the story with transfusion and chelation. It can be very successful if it's monitored properly and it's given in a timely way. But there's a lot of interest in other treatments, and there are a lot of new novel therapies around. I'm not going to review the trials in any detail, but they aim to do a number of things. But if you're trying to think about how they might coalesce, they're trying to decrease ineffective red cell production, which is the hallmark of thalassemia. And this can be achieved by promoting fetal hemoglobin, or alternatively by antagonizing hepcidin. There's a study on JAK2 inhibitors which shows that you can shrink the spleen. And then there's the activin receptor traps. ACE11 and ACE356. A couple of slides, this is going to be shown in more detail later. This is from data shown by Antonia Piga at the EHA meeting. You see the hemoglobin in non-transfused patients increases by up to 2 grams, and it's quite a reliable increase in hemoglobin. And this works by acting as an activin receptor trap and possibly inhibiting GGF-11 signaling. The absolute mechanism isn't entirely clear. And if you look at the same drug in transfused patients, the amount of blood that patients get can be very substantially decreased. So if this could be combined with transfusion and chelation, we could decrease the demand for blood and decrease the demand for our chelation. So if this translates in the long-term studies, this could have a major impact on how we manage our patients. That is non-curative therapy. I have to mention curative therapy, hematopoietic stem cell transplant and gene therapy. The hematopoietic stem cell transplantation was first done by Thomas in 1982, and the major studies were done by Lucarelli and co-workers in Pesaro, who established the risk factors, class 1 to 3, which are still used today. And I'm not going to go through that in detail, but the point of this next slide is to show that mortality from hematopoietic stem cell transplantation from a sibling has dropped substantially during that period, from around 37% in this particular study to 27%. So it's becoming a safer procedure, and as a result of this, it's now recommended by many groups in Europe, for example, for young children before they become severely iron overload who have a matched related sibling. And I think that bone marrow transplantation, particularly from mud types and haploidentical, is going to be expanded, although this must be regarded as experimental to a large degree at the moment. With gene therapy, the objective is to transfer the beta globin into stem cells and reduce the alpha-beta imbalance, increase the normal red cells and reduce ineffective erythropoiesis, and ultimately become transfusion independent. That has been the long-term objective. Gene therapy has been around since the 1980s with the initial programs, but it wasn't successful in mouse models, and early studies with retroviral vectors were disappointing. With the revival, by using lentiviral vectors, there was a revival in interest, and now we have a successful demonstration of gene therapy in patients using lentiviral vectors. So this is the famous patient with E-beta thalassaemia who received myeloablative busulfan conditioning followed by lentiviral vector to correct the hemoglobin. This patient is now around 8 years out and it has stable hemoglobin and is transfusion independent and has no significant side effects. This study is now being expanded by Bluebird Bio into larger studies, and we're involved in one of those at our center. And there are early results of that which are going to be presented at the American Society of Hematology. But essentially, the production technique and the vector copy number is becoming more and more efficient. And so obtaining higher hemoglobins is very likely. So what is the future outlook for thalassemias? We have non-curative, improved iron overload and improved use of chelators. I haven't talked in any detail about that. I think Ali Tai here is talking about that tomorrow. Improved safety and provision of blood. I've not talked about that today. We need safe blood, and there's going to be a satellite symposium on that tomorrow. Improving dyserythropoiesis, well, the activin receptor traps do that to some extent, but there's many other approaches such as hepcidin agonists which are very promising, particularly in mouse models. In terms of curative, we've spoken about gene therapy. with lentiviral vectors, but there's at least 4 groups worldwide working on this, and the idea of CRISPR technology is appealing, although it's very early days with that. That might have some advantages over the lentiviral approach. And improve safety and scope of allogeneic transplantation. Okay, just to be fair, even though there aren't many sickle doctors in the room, I will just say a few words about sickle cell disease. What's interesting about sickle cell disease is, although it was the first molecular disease that was discovered, its translation into effective treatment has lagged behind that of thalassemia. So whereas transfusion and chelation has been a massive success in thalassemia, we haven't really had that speed of massive increase in the quality of life and survival in the sickle patients. It's not to say there haven't been successes. So it was the first molecular disease that was discovered, its inheritance was discovered, its structural basis was discovered. The importance of fetal hemoglobin in leading to a more benign disease was identified way back in 1972. And I think an important bit of work, which is now bearing fruit, was the work of Hebel, who showed the importance of the adhesion, the stickiness of red cells and white cells to the endothelium and to the severity of sickle disorders. So in terms of managing sickle cell disease, what are the important milestones? Prophylactic penicillin, major impact. Transfusion for severely affected patients with stroke, major impact. But we didn't have really good control data until the STOP studies in 1994, and then more recently the study for silent infarcts, which has yielded some fantastic data on the benefits of transfusion. Stem cell transplantation, a lot of really good data now. I'm not going to go through that. Then, of course, hydroxyurea, hydroxycarbamide. This has had a big impact on the frequency of vaso-occlusive crisis and chest syndrome. The extent to which it reduces stroke is controversial, and it's not a perfect drug. I think we need better drugs, and so that can be argued. Newborn screening, we have universal screening in the UK for sickle cell disease, and that's been very successful. And now we have the first case of gene therapy for sickle cell disease, which was published earlier this year by Rebbe, using a similar technique to that used for thalassemia by Bluebird Bio. So, have we reached the end? No, I've nearly reached the end of my talk. Not yet, because prevention of births is still highly variable between different regions of the world, different countries, and even between regions within countries. Diagnostics are not universally available. You go to some countries, they say they've got T2 star, but it's called a T2 star, but it's not a T2 star. It's a big problem. Non-curative treatment is not available in many countries. Some countries still don't have safe blood and affordable chelation. So we've really got to work on that. Curative treatment by stem cell therapy needs to be affordable, as does gene therapy. So we're very much in the early phases of gene therapy. It's incredibly expensive. How are we going to be able to roll that out worldwide? Curative therapy is very attractive, but we have to make it affordable. We also need the infrastructure in many countries to support chronic disease. Even in the UK, there are many parts of the country where we just don't have the doctors, we don't have the nurses, we don't have the support to get the best outcome. And one of the roles of TIF, I think, is to help people to maintain and get a good group of people together to get the best outcome. So science and technology are ahead of the organisation and funding of healthcare systems. And this is a real problem worldwide, not just for thalassemia. So, have we reached the end? I apologise for quoting a former Prime Minister from the United Kingdom, who, when asked after one of the first successful battles in the Second World War, we're nearly there yet. He said, "This is not the end." I think it's very appropriate for thalassemia. "It is not even the beginning of the end, but it is perhaps the end of the beginning." Perhaps we're at the end of the beginning. Thank you.